Recording in progress.
Good afternoon, attendees. Welcome to the Osteoporosis and Fall Prevention Festival organized by Satacom Health. I am Dalila, your host for today. Let's welcome our acclaimed speaker, Dr. Gurpal Singh, who is a consultant orthopedic surgeon at Mount Elizabeth Novena Hospital, who will be sharing about knee pain in the elderly. Dr. Gurpal Singh is a board-accredited fellowship-trained consultant orthopedic surgeon who has subspecialized in tumors of the musculoskeletal system. He was awarded in the Ministry of Health Scholarship for Advanced Specialty Training. Dr. Gurpal Singh has spent 2 years in Germany. Take note that you're only able to ask questions during the Q&A session at the end of the talk, either through the chat box, Q&A chat box, or you can raise your hand so that we can unmute you. Now, I'll pass the time to Dr. Gurpal Singh.
Hi, thank you for the kind words and thank you for allowing me to share my thoughts today. Session today is on knee pain in the elderly, and I thought we make it meaningful by sharing some stories of real patients that I've treated. So in a nutshell, I know it's Saturday afternoon and we're not really in the mood for something very heavy and boring. So we'll try and keep it as simple as we can. So when we discuss bone and joint pain, in general, we can think of the problem according to age group. For young patients, the commonest reason for having bone and joint pain is really due to sports injuries. Now, once we hit 45 to 50 years, some degree of wear and tear or arthritis usually sets in. Arthritis is not just limited to wear and tear, but for purposes of today's talk and keeping the discussion simple, we will equate the two terms, arthritis meaning wear and tear. Now, less common but serious are infections, tumors, bone cancers, and I would say it's roughly 5 to 10% of cases as the age increases, which is, it might seem like a small number to the layperson, but to us, it's a reasonably alarming number, 5 to 10%. So now if we look at a model of the knee here, and I'll illustrate this with a little model that I have over here. If I were to open the knee up and look inside, this blue area that you see over here, that's the nice good cartilage or the lining of the bone that we see. And now if I show you the next picture, what is really arthritis? Arthritis is the wear and tear. A lot of people ask me what is really what wears out. So it's the lining, the blue lining here that wears out. And it's not the bone that starts to wear out, it's the cartilage that starts to wear out. And it is not to be confused with osteoporosis, which is basically the bone becoming hollow or the loss of bone mass. What are the symptoms of arthritis? You have good days and bad days. Pain on climbing stairs, walking, some swelling, you can have stiffness, and sometimes if the arthritis is advanced, you can have deformity. You can have things like bow legs and so on and so forth. And this is a picture that I like to show in most of my talks. See, nobody comes to see me when you are absolutely normal, which is the picture on the left. And the picture in the middle shows some early wear and tear, which is, again, referring to this blue cartilage. It's not blue in real life, it's blue on the model, but just for purposes of illustration. And the picture on the right here shows a complete breakdown. This is the analogy I sometimes give is the car has broken down and you need now a tow truck to bring the car to the workshop. So this is advanced arthritis. What we would like, and the message of this talk, if I can give this message, and you know, I would consider the talk a success if this take-home message can be remembered by everyone, that please come and see us or go and see your doctor when you have early wear and tear, i.e. don't ignore your symptoms. Don't ignore your bone and joint pain. Don't attribute it to it's a normal process of growing old, because there's a lot we can do when you come, when the wear and tear is early. Most patients do not need operation, and if you do, the operations that you need are very small. But when you come late, then the operations that you need get bigger. But it's not saying that we can't do anything. But definitely we need bigger surgery. Now, just for the record, most patients, about 90% or so, come when you are in category number 3. Only about 10% of the time I'm seeing patients when with early wear and tear. And so the purpose really of these outreach talks is to educate people and let them know that no one should be on a wheelchair because of arthritis. Nobody should lose their independence and mobility because of bone and joint problems. Please see your doctor when the problem is still in its early stages and discuss your treatment options. So the majority of people do not need any surgery. And even if you do need surgery, if you come when the problem is early, it is a small operation that needs to be done. Conservative treatment or non-surgical treatment involves management of weight, the use of medical aids and appliances like walking sticks and frames, for example, the customized use of physiotherapy, medicines, injections, and so on and so forth. Now, injections into the knee joint, these are very straightforward procedures. They take less than 10 minutes and you can go home immediately. It is something that, if done in the right setting, can make a very big difference in the pain levels of the patient. Knee guards, knee braces can help to stabilize the knee, bring about pain relief, minimal risk, but sometimes you can't be too dependent upon them because the muscles get a bit weak. Lifestyle modifications, it really depends on where the problem is. So for example, I just saw a patient this morning who is an avid cyclist. And when you cycle, you will wear out the front of your knee because you're doing this again and again and again. So this is the front of the knee that was getting worn out here. So I'm trying to adjust his activities such that he balances out. He has his cardio workouts, but perhaps a bit more swimming, perhaps a bit more brisk walking, even jogging on soft ground, and slightly less stair climbing and squats and leg presses and cycling. So that there are ways to sort of balance things out. But the key thing is to see your doctor to get an idea of where you stand. Everybody is different. Some people might have more wear and tear in the inside part of the knee, for example. So it's good to have an idea of where you stand. It's not a one size fits all approach. Now, medication can be a useful thing in the short term, but it can become problematic in the long term if you need to take it every day. And I mean this in the specific context of joint replacement, joint problems, knee problems, hip problems, and bone pain, and so on and so forth. If you take anti-inflammatory medicines and painkillers every day, they can have an effect on your stomach and your kidneys. And this is not what we want. So we must solve the problem at the root cause and not keep on suppressing the problem. This is a whole variety of walking aids that I'm showing in the slide. And the umbrella is really a very creative one. And the umbrella with the rubber stopper at the bottom is very important because you don't want people falling. Yeah. So while appearances are important, we don't want anyone falling. Falling creates its own set of problems, big problems, and we don't want to substitute one problem with another problem. So be very careful in terms of the stability of the walking aid, especially when wheels are involved or when slippery surfaces are involved. So what about surgery then? What is the role of surgery? So as mentioned earlier, if the problem is early, we can do small surgeries if there's a need to. But if the problem is advanced, then we need to do replacement or joint replacement surgery. So keyhole surgery, this is a cartoon picture showing what keyhole surgery is all about. But perhaps to make things more clear, this is a picture during the keyhole surgery that shows what's happening inside the knee. And in this case, what we are showing is, just to put things in context, the instruments, the one on the left is 5 millimeters, half a centimeter. And the one on the right is 3.5 millimeters, 0.35 cm, the size of that instrument, the width of that instrument that you're seeing. So this is a very magnified or blown up picture that this is the picture we see on the screen when we have a camera inside the knee, and this is keyhole surgery. So what you are seeing there is a small area of the cartilage here that has a hole in it, or it's a bald patch. Yeah. So what we are doing now is this is the unstable cartilage. There's a bald patch of cartilage there, and we have then done a patch repair of that cartilage, a little bit like how we do a patch for a punctured tire. Yeah. But this is possible if the problem is early and is localized to one area of the cartilage. This picture is now showing during keyhole surgery what a meniscus tear looks like. Meniscus. If you look here, these are the menisci, or the two meniscus in the knee. Yeah, this is like the cushion or the shock absorber of the knee. So if you look here, it's between the two bones. You have the cartilage and the meniscus. And in this case, the cartilage was normal, but there is a tear of the cushion or the meniscus. So what this is showing is we're shaving the tear to make it stable, and then we will use a stitch and repair the tear. Everything done in keyhole. And this is to put things in context. When we say keyhole, we mean keyhole surgery. This is the wound that you have on the skin. It's 2 1-centimeter cuts, no big incisions, and everything is done with a camera inside, with instruments inside. Go home on the same day, and the stitches are removed at 2 weeks. In these 2 weeks, most of the time patients are walking. Sometimes when we have done repair work and reconstruction work, we have to slow you down using crutches for about 2 weeks or so. So this is what it looks like. These are small surgeries. If we need to do them, it's only possible when patients seek treatment early. So now what happens when patients come late? then we need to talk about joint replacement. Now, what is joint replacement? That's using the knee as an example. We have joint replacement where we can show partial replacement and full replacement. Let me see if I have a model. Yes, I do have I'm doing this from my office. So I have a model here. So this is again a model of a knee replacement. And if I take this out, what it shows you is you don't have to cut off the whole knee. Some people have asked this question. We shave the bone and over here and over here. This is what we need to do. And this is the artificial knee that we fit in. This is made of cobalt chrome alloy, special metal here. This is titanium, and you have a plastic piece in there, which is usually polyethylene, ultra high molecular weight polyethylene here. And this becomes like this. Then what you do is, during the surgery, after the bone is shaped into what you need to fit the prosthesis, you put a new knee on the top and the bottom. I wish it was this simple, but yeah, for purposes of illustration, that's what you have. And then you have your new knee there. Okay, now this is the option of choice if you come when you are advanced. That means just now the picture that we showed, the car that has already broken down and you need a tow truck to bring it to the mechanic, me being the mechanic. So here you have a long cut after the surgery. You have to do this open, and you need about 3 to 4 days of hospitalization to recover. Now, what happens after knee replacement surgery? With newer techniques like robotics and newer, better implants, better surgical techniques, things are getting faster. And this is a picture. As you can see, this is one of my patients. This is at 1 week. You can see that on the left, this is 1 week. The dressings are still on. So with newer techniques like robotics, patients are walking faster, better, and we have much shorter hospital stays. Sorry. So newer technologies such as robotics are changing the game. So the surgery for knee replacement is becoming smaller. It is becoming more accurate, and we are having faster recoveries. The implants are lasting longer. This is another example. I want to show this. This is a very patient that has inspired me a lot. I've just done this case not too long ago. You can see bow-leggedness here. Bow-leggedness is a common deformity that we see in our population. And a lot of us, if we take a look this evening when we are out and about whether we're taking a walk or whether we're at the kopitiam, we will see this problem. And this is a lady who has been living with this, looking after the family, looking after everyone except herself. And she's suffering now with severe arthritis. This is severe deformity, bow-leggedness. And this is what the x-rays show. One side of the knee is so badly worn out that it's causing the bowing. Also, the kneecap, the front of the knee is badly worn out. So we did a robotic-assisted surgery, and that's the picture of how the robotic-assisted surgery is done. That's me standing there on the right, and the robot is not autopilot. I still have to do the operation. The robot helps me with the accuracy of how I make my bone cuts. Because I often say, if I ask someone, this is unfortunately with these webinars, we have to be a bit creative, but in the past when we had physical talks, I would often do this. I'd ask everybody, take out your mobile phone, and using another surface, I'd ask everyone, please show me what is 40 degrees. So if everyone can do that, maybe you can take out your phone and see what is 40 degrees. Then I would go around and look. Everybody would have a slightly different 40 degrees. And this is reality. We as human beings don't have certain limits in our resolution when we look with our eyes. So when we do surgery, we really need to be accurate, and robotics helps us with that. So we do a CT scan of the patient's knee, we feed the CT scan back into the robot, and we do a customized knee replacement for that patient. So this is the difference. And it is useful in the sense that it is almost like doing a surgery with 3D glasses on. So in addition to that, infection control is of paramount importance. Infection control is so important that when we put in these metal knees and all that, we really are worried that there's a 1% risk of infection most of the time, but we are so worried that we'll get this infection that we really need to take a lot of special precautions. And you can see that we are doing this operation with space suits on. We are not this is not normal surgical attire. Normally we wear masks and caps and gowns, but for these operations we have special operating rooms, we control the airflow, and we use these space suits with internal ventilation systems so that there is absolutely zero exchange of secretions in any form between the surgeon, the team, and the patient. And this is what we see during surgery. We have a plan based on the CT scan of the patient. As you can see, this is the additional advantage that robotics gives us. We can see how many millimeters, exactly to the millimeter, that the joint space is opening up, so that there is no element of guesswork or aggravation, as we call it. No guesswork left. So we are doing things in an accurate way, and we are able to overcome our human deficiency of not being able to use our eyes to that level of resolution. I don't think we can tell the difference between 19 and 20 millimeters just by eyeballing. This is where this technology helps us. Technology is not a substitute. Technology is, I call it, it's like an extension of my pair of hands. It helps me to be a better surgeon. It's like wearing a pair of 3D glasses and operating. And this is what happens during surgery. Just to show you, this is the kind of movement we can get after a knee replacement. This is the knee replacement has been completed. And those are the instruments that I use to communicate with the robot. And as a matter of fact, I always get my team to record. Of course, I can't be recording these videos. When I do a knee replacement surgery, I record these videos and I use them to motivate the patient thereafter when they do their physiotherapy. I always tell the patient, during the surgery, we managed to achieve this level of movement. Now, no excuse to be lazy. We must get that. And what are we able to achieve? This is what it looks like after surgery. The leg is straight. And this is the same patient 3 days after knee replacement in the ward. This is in the ward. And this is, she's doing her physiotherapy, walking with a frame. And at 2 weeks, she was walking independently. So this is showing 3 days. And now let's see her 14 days. When we did, this is 14 days in my clinic. We took out the stitches at 14 days. And the problem is that she's in imbalance because one side is now straight and one side is still bow-legged. So this lady that you see has had knee replacements as well. And she wanted to sit cross-legged because this was important to her. She was able to do so. This picture is roughly about, I believe it was 5 to 6 months after surgery. And this illustrates the importance of proper rehabilitation. And also, a lot of us feel that there are a lot of things we can't do after surgery. Talk to your doctor, discuss your needs, and that's the most important conversation that you can have. Once the doctor knows your needs, he or she can tell you frankly whether you can achieve what you are trying to achieve or not. The picture, why we put a cycling photo there, I've just done a knee replacement in a 52-year-old, young 52-year-old who cycles 200 kilometers a week. And he's back to doing 150 now. And this is achievable. Well, I always tell my patients, you can't go bungee jumping and you can't go skydiving, Maybe I'm not going to let you run on hard ground, but some degree of sports, cycling, swimming, things that don't involve impact and range of motion, being able to sit cross-legged, these are no longer things that you can't do. You can do them, provided you have a frank discussion with your doctor that these are the things I want to do, and then your doctor will tell you whether you can or cannot. And if you've decided on a certain goal for yourself, then you and your doctor should make plans, use these tools that we have like robotics and new technology to try and achieve your goals. But these are the x-rays after knee replacement. What you're seeing on the left is a total knee replacement, and on the right you're seeing a partial knee replacement where not the whole joint was involved, so you don't really need to replace the whole knee. And this is what a surgery of a partial knee replacement looks like. One of my patients told me it looks like you're playing a computer game. He's not completely wrong, but yes, we're not really playing a computer game. We're doing the operation, but this is the feedback that we are getting from the screen during the surgery, so that we are not cutting anything absolutely more than necessary, and we are making the surgery a lot smaller, and the patient then, for a partial knee replacement, goes back the next day. This is one of my patients after partial knee replacement. This is at 6 weeks. 6 days. The dressings are still on. This is 6 days after the surgery. Yeah, 6 days. So I know it's a Saturday afternoon, and I haven't forgotten that. But the one of the things that I want to share, remember the third point on the slide was that 5 to 10% of patients will present with pain that is not due to wear and tear, and something more serious like infection and tumor. So when do we need to be extra careful? When pain happens at rest, when you're not doing anything and you have pain, when pain happens at night, when we have things like loss of weight, loss of appetite, fever, these are to be taken seriously. Please talk to your doctor. I want to end this talk by sharing another story of one of my patients who has been a big inspiration for me, and has inspired many of my patients and colleagues. I will never forget his story, and I usually share his story at the end of my talks. For those of you who might have heard this before, I sincerely apologize, but he has inspired me so much that I just have to share this. And he at that point when I treated him, he was 70 years old, avid golfer, and he developed some pain in the left thigh after missing a step. The pain persisted, got worse. And of note, 5 years before, he had a history of kidney cancer, and the kidney was removed, and he was told the cancer is cured, rightly so, because the kidney was removed. And what we found was that on the side where he had the pain, the hip was almost like it was eaten up. It's a little bit like how you have termites eating the door, or the ants that eat the wood. When we did an x-ray, that's what we saw. And we did a biopsy, which means we took a needle sample of that area, and it showed kidney cancer cells. Now, the kidney in reality is already been removed 5 years ago, and the other kidney was healthy. So 5 years, somehow, these cancer cells were sleeping somewhere in the body, and now they came and settled down on the bone around the hip and started to eat the bone. And this is not an uncommon story that we are seeing now. So what we did was, we did a hip replacement. Now, this is not an ordinary hip replacement. We have removed the tumor, and we've reconstructed the back of the pelvis bone, and we've done a complex hip replacement, as you can see, over this. And this is him at 3 weeks. And to be very honest, I was a little upset when he did this, because this was not a planned visit. I had told him for 6 weeks, no walking, go on a wheelchair. And this gentleman at 3 weeks paid me a surprise visit and said, oh, I came for my radiation therapy and I decided to say hi. No stick, no walker, no nothing. And I was really a little bit upset with him. He said, my surgery is going to fail. And the one thing he told me was, which I never forget until today, he said, doctor, Why don't you have faith in your surgery? I have faith in your surgery. And I want to let you know, I have already played 9-hole golf. And I was, of course, I was taken aback, and I said, please don't do this. The surgery will fail, and my hip replacement will fall apart. You need time to let your body heal. But I realized from him what the power of willpower is, what a positive faith can do for you. And the honest truth is, he was right. I was wrong. And he did well. He moved, this gentleman was from Indonesia. He moved back and went on, fast forward another 4 years. This story is about 6, 7 years old. Fast forward another 4 years, he developed spread of the cancer to his lungs, and he passed on. And his family wrote to me, and they still keep in touch, and they shared with me that a very touching email saying that thank you for keeping him mobile until the end. We couldn't have seen a more peaceful way to go. He was happy until the end, because independence and mobility was so important to him. And I wrote back to them saying that it really wasn't me who did anything, and he had such a positive outlook towards life, and he was so motivated that was the reason that he did so well. But I have been so inspired by him that I always share his story at the end of my talks as the last case story to inspire everyone that despite having cancer that had come back, he did not give up on his zest for life. So with that, I think we can sum up this talk. And in my conclusion slide, I just want to make a few points. Osteoarthritis of the knee can be treated effectively. Joint replacement surgery is not the end of the world. It gives predictable, good results, such as, especially when newer techniques like robotic assisted surgery are considered. Talk to your doctor. Try to see your doctor early, because if you see your doctor early, smaller things may have to be done, or better still, no surgery at all. 5 to 10% of the time, things are not what they seem. It can be something more dangerous like infection or tumor. Especially if you have night pain, rest pain, weight loss, please see your doctor early. So with that, I thank you. I'll leave my number and my contact there in case anybody wants to reach out. Sometimes questions are of a more personal nature, and I have received feedback at previous talks that it's some people are not too comfortable asking these questions openly. So I'm happy to share my number and my email there. I'll just leave this on the screen for 10 seconds if anybody wants to take a shot of this. And I do have to apologize that if questions are of a personal nature, sometimes I can't answer them very effectively because I haven't seen you and I haven't examined you, and a general answer sometimes doesn't really do any good. So I will do my best to answer any questions there are, but where I feel that without seeing you in person or examining your knee, I can't really do justice to your question, I will be honest with you and let you know. I think if you've had enough time, so I think we will then move on. And okay, so are there any questions that we have? Perhaps we can take questions. Okay, I'll open the question. If you have any questions, please type them into the Q&A box, and I'll do my best to answer them. So let's go one by one. So the first question is, do you recommend hyaluronic acid injection into the knee if the cartilage has worn off? Thanks. Now, this is a very good question. And the honest answer is it depends. It depends on your individual situation. There are various options in terms of what we can and cannot do. And I did not go into the details of the types of injections, but there are basically two types. One is steroid-based and one is hyaluronic acid, or what we call viscoelastic injections. And it depends on your situation. Injections can be used as a treatment modality on their own, or they can be used as part of another plan. For example, keyhole surgery plus injection, plus physiotherapy. So it really, really depends on how bad is your cartilage wear and how early or how late your arthritis is. If it is late arthritis, like the picture I showed, number 3, or the car has already broken down, frankly speaking, hyaluronic acid injections are not going to do very much. But if it is early arthritis, localized cartilage wear, there is a good role for these injections, either on their own or in combination with other treatment modalities. So please speak to your doctor and have an individualized or customized treatment plan for yourself. Question number 2, are there any side effects after knee surgery? Thank you very much. Again, this is a very good question, but I think it's a bit too broad for the scope of this talk. It depends after what kind of knee surgery are we speaking about. So we touched on 2 types of operations today. One is the keyhole procedures and the other one is the replacement procedures. So it also depends on whether the patient, what is the age of the patient, whether there are other medical problems like diabetes, heart problems, for example, and how big is the surgery that we are doing. So to put things in context, a young 30-year-old who has a sports injury, undergoing a keyhole surgery, no other medical problems, has probably a 1% risk of any problems or side effects. And these can be in the form of, complications can come in the form of, say, infection and problems like that. More commonly, we are seeing things like not being very motivated for the physio, not doing the physio, getting busy with work, and the muscles are not recovering properly. Now, those are not really side effects. Those are problems that are preventable. And again, we need to have frank, open communication between doctor and patient. If we're looking at someone much older, having diabetes, heart problems, for example, undergoing a knee replacement surgery, certainly the risk profile is a bit more. You're looking at a 3 to 5% incidence of infection if the diabetes is not well controlled. This is why, personally, if the diabetes is not well controlled, I don't operate on the knee until and unless the diabetes is controlled. And I work with other specialists to do that and the patient, because the risk of infection is just too high. You can bring that risk down to slightly over 1% to 2%. Now, other issues like blood vessel injury, nerve injury, all these problems, they are very, very low risks and they should not happen most of the time. I often give the analogy of, it's the same risk like if when you get into an aeroplane, what is the risk of the aeroplane crashing? Someone turned around and said to me, oh, but nowadays with COVID, maybe the pilots haven't flown an aeroplane for a long time. And I said, okay, let me just take this up in the context of, let's not bring in an additional complicated layer to that. I'm pretty certain that, our pilot colleagues are doing all they can to keep in touch and something, so if we look at the situation without this comment that a patient of mine recently made, yes, I mean, what is the chance that we get into a plane and the plane crashes? What is the chance we get into a car on the road and we get into a car crash? What is the chance that we look left, look right, cross the road on a zebra crossing and get hit by a car? So this is how I would give the analogy of side effects and complications. But I think a detailed discussion of this is beyond the scope of this talk. It is an individualized issue, and you need to discuss that with your doctor in an individual way. So the next question, what about knee pain due to weakened muscle support? Thank you. This is a very good question. Again, this is very broad. Weakened muscle support can be due to a lot of factors. It can be due to injury, it can be due to surgery, it can be due to any surgery will weaken the muscles. So the short answer is that there's no shortcut to this. You need to work with a physiotherapist and strengthen those muscles in a targeted way, and that's the short. In a short term, you may benefit with the knee guards and braces, but long term, honestly, there's no good shortcut to this. But it depends on the context. It really depends on the context. So those are the questions I have on the chat box here. Let me open the other chat room and see if there are, okay, there are some comments and questions. May I know if deep squat means cannot go all the way down? Yes. How far down? Thank you for this question. Again, it depends on an individual context. I won't be able to give you a meaningful answer for your context because I haven't seen your knee. For some patients, a deep squat is okay because if the front of the knee is not worn out, there's nothing wrong with doing a deep squat. In fact, it's good for you. But if you have wear and tear in front of the kneecap, then a deep squat can be harmful in the sense that it can worsen the problem. So you need to have a discussion with your doctor and your physiotherapist or your personal trainer or whoever's helping you make that exercise plan for yourself. And you don't have to go to fancy, I don't mean that you need a fancy personal trainer. No, I don't. You can discuss this with your doctor once. You can make a very simple plan for your exercises and you can do them yourself. Okay, there's no need to go to a gym or anything of that sort. This can be done at home. You can do it in a park connector. You can do it anywhere. But the most important thing is you should know, maybe based on an X-ray, MRI, or even a combination of your knee clinical examination, X-ray, sometimes MRI. What you should have is a roadmap of what is your wear pattern of the knee. If you know your wear pattern of the knee, you can then offload the areas that are worn out and you can redistribute the load to the areas that are still holding. That's the concept of it. I hope I've answered the question. I've already addressed the hyaluronic acid. The next one, after knee partial full replacement surgery, is there any symptom patients may experience long-term or pain unresolved? Does such condition happen? What are the indicators or red flags we should observe and strongly encourage patients to go for patients? I've encountered many patients who are always skeptical on getting a surgery, to go for surgery. That's a very good question. I think most people are skeptical. We need to, generally speaking, like most of us doctors would try conservative non-surgery methods first, like physiotherapy and lifestyle modification. Only when those fail, then we would recommend surgery. And everybody's surgery is different. It's not possible to compare one for the other. If there are long-term issues or pain is not resolved, yes, it can happen, but the most important thing is we must go into the situation and see why does it happen. The medical literature reports about 10% to 20% of patients who are not very happy with their knee replacements after 1 to 2 years. And often the reasons for not being satisfied are a mismatch of expectations, for example. So I think what is needed is a frank and open discussion with your doctor. And if there's an issue, you're still having pain, then is it a complication? Is it, your muscles are not acting properly, your muscles are weak? So this basically is something a little bit beyond the scope of this talk, but it's something that needs to be discussed with your doctor. And in a systematic way, you can do a clinical examination, sometimes x-rays, blood tests, and see, is there an objective problem? For example, if there is, then can the problem be solved? If not, then is it an issue with muscles? For example, after knee replacements, we see this very commonly that, rehab sometimes patients don't do, and then the muscles are weak. So those problems are generally related to muscles, and we can then encourage them to do more physiotherapy. So it's a very individual discussion. How long does the total knee replacement last? Is it 5 years? Is it true the younger patient she or will have to go for more than one knee replacement? This is a very, very good question. And the honest answer is it's not 5 years, it's much more than 5 years on average. So maybe if I were to draw this for you, it is like a bell curve. And so if I were to show you this, yeah, it is like a bell curve. And the center here is about 15 to 20 years. You have those that even last longer and those that fail earlier, but the vast majority will fall here. So with newer implants, newer technologies, we hope to push the envelope beyond 15 to 20 years. But the new technologies and new implants have come on board quite recently. So we will only be able to tell over time whether we are pushing the limits. But definitely it's, I would say the average is 15 to 20 years, or maybe I should put it like that. We use data from registries, from national registries, to look at the survival of knee replacements. And most registry data from whether it's Europe, Australia, New Zealand, and most registry data in big countries, developed countries, suggests that there's a 90 to 95% survival rate of hip and knee replacements, even beyond 20 to 25 years. So this the statistical chance that if you do it young, you'll have to go for one more. In theory, yes, but the question really is for patients with young patients with arthritis, and this is something that I'm very passionate about because it's very close to my heart and something that I chose to go very deep into. It is easy for us to say, oh, don't do anything because you might have to go for another knee replacement next time. But I've seen patients who are very frustrated because their quality of life is suffering. And one of my patients turned around and said to me, how do I know what's going to happen in 15 years, 20 years? What I do know is that I want my quality of life today. I want to play with my children. I want to do some light sports. I want to travel the world. Of course, this was pre-COVID. I hope we get there soon. But so, and this is reality. So the question really is, yes, in theory, if you do a knee replacement when you're young, you might have to go for a redo surgery at some point, but not always. It also depends on how much you use the knee, how much the knee wears out, and so on and so forth. But the more philosophical question really is, do you want your quality of life today? Today means in this period, 5 years, 10 years. These are the prime years of the life. Or do you want to suffer and wait until 60, 65, whatever, and then do the knee replacement, suffer 15, 20 years or for 10 years, 15 years, and then get the knee replacement done just to avoid the theoretical possibility of having a redo surgery? And that's really the way to think about it. So with newer technologies, newer implants, we hope we're going to push the limits of implant survival even more. But the key question is really quality of life. And if you find that your quality of life is getting to a point where it is really, really compromised, then you should really ask yourself this question. Yeah. So, yeah. I have been having knee pain for about 10 years and recent years pain during sleep. I suggest that you must get, okay, so if you've been having it for 10 years, yeah, that is significant. It's a long time. And if you have pain during sleep, the short answer to that is that you need to see your doctor and get a checkup done. It is not always something serious, as I've mentioned, but the chance of something being serious, if rest pain and night pain are there, is slightly more than if it's just mechanical. So I do think that the whole point of this outreach is that don't ignore it. Please go and see your doctor. I wish you the best. I sincerely hope it is nothing sinister, but I would advise you to get a checkup, and I wish you the best. Yeah. Yes. I've had hip osteoarthritis and occasional knee pains. Is cycling for 30 minutes good? Since you mentioned cycling is not good for knee pain. Uh, that's not true. I did not say cycling is not good for knee pain. I said it in a very specific context, that if you have wear and tear of the front of the knee, then cycling may make it worse. But if the wear and tear is not so much in the front of the knee, then I'm not saying that it's bad. And to be honest, I cycle myself. So, but I'm just a very recreational amateur cyclist. But I cycle with my children, so it's not bad. Um, it's an individual context. You have to look at your context. So it is not enough to say, I need to know what is the pattern of wear. So in this context, I would suggest to you, I don't think you should change your activities unless and until you've seen a doctor, you've gone through a detailed discussion, you've mapped out your arthritis, and if I can be of further help to you, I've given my contact there. I'm happy to go a bit deeper, but I think it's difficult to do this online on a platform like this without seeing you. To protect the knee, is it recommended to wear a knee guard during jogging? Again, knee guards generally make us feel very good, but the best knee guard is your own quadriceps muscle. So if you have developed your quadriceps well, then you don't really need the knee guard. But it depends on whether you have wear and tear of the front of the knee or even the deeper parts of the knee. So if you have wear and tear combined with a weak quadriceps, then you would find that a knee guard really seems to help you, which is okay for the short term. I'm not saying knee guards are bad. Knee guards are useful, but it would be better if you can strengthen up your quadriceps, because that's your best natural knee guard that you have. Any supplements that can help to slow down wear and tear in the knee? Yes, I was just waiting for this. There are a lot of supplements that I find people are taking, and I often, one of the most essential ones is vitamin D for Denmark, and that's in general good for your bone health. And we're finding a lot of people deficient in vitamin D more lately, but it is not directly related to wear and tear. I'm saying it for bone health. Other supplements like glucosamine and so on and so forth, the scientific evidence is rather mixed, and if you ask me, is there any hard evidence that it slows down wear and tear? The evidence is weak, but a lot of people liken it to a bit of a win-draw scenario. Like if I take it, if I think it helps me, then I'll continue. If not, then I'll stop after 3 months. And I think as long as the supplements are taken from a reliable source and they don't cause any harm, I think that's a reasonable approach. There is some newer evidence that is suggesting that maybe some of these glucosamine supplements might worsen sugar control in people who are already diabetic. Again, the evidence is, the details of that are beyond the scope of this discussion. So I would suggest to you that it is not a bad idea to take supplements, but it's always a good idea to discuss it with your doctor once. It wouldn't be right for me to make blanket statements about taking supplements for you, whether it's good or bad for you. Generally, supplements are good, and there are positive benefits that we can achieve if we take it the right way. But you need to have a discussion with your doctors. Yeah. Can we practice Tai Chi with knee pain? Absolutely, yes. This is a very short answer to that. Answer is yes, and you will benefit more than it'll do you any harm. But again, you need to have your individual situation looked at. Where is your knee pain? What is the cause of the knee pain? what is the degree of wear and tear, and so on and so forth. I see Delilah there. Are we okay for time?
Yeah, that's all. Thank you, Dr. Gopal.
Are we okay for time, or I have about 1 or 2 questions more. Can I continue, or should I stop?
Yeah, I think you can stop now because the questions can be sent to us and then we are able to send you.
Okay, so I'm mindful about your time, and thank you for this opportunity to share. Thank you to the listeners for sending these questions. It made the discussion very meaningful. I sincerely hope that I've been able to answer. I tried to do so in as frank a way as I could. I apologize if I was not able to cover some of the content, because sometimes things are beyond the scope of a talk, and I'm happy to take any questions. If I've missed out on anything, if anyone wants to reach out to me, I shared my contact as well. Yeah.
All right, thank you, Dr. Gurpal Singh, for sharing, and thank you, attendees, for attending the talk. We hope you have enjoyed the session, and I hope to see you soon in other webinars that we will be organizing. If you have any inquiries on what was shared earlier, feel free to drop us an email at mediacontact@sata.com.sg or call our hotline at 6244-6688. Stay safe and healthy, everyone. Goodbye.
Thank you.